Hey everyone, and welcome to this explainer. Today we're going on a really fascinating journey. We're going to start way down at the microscopic biology of disease, and then we're going to zoom all the way out to a macroscopic view of how society itself actually impacts our well-being. We are diving into the sociology of health and illness behavior. Think about this for a second. Why do two people with the exact same diagnosis end up with completely different health outcomes? I mean, if biology were the only factor at play, a specific treatment should yield the exact same result every single time. But it doesn't. We've kind of been trained to think that germs and genetics are the only things that dictate healing. But as we'll see today, the reality is far more complex, and it's heavily shaped by our environment and our social structures. Okay, let's dive right into this. Here's our roadmap. We're going to start by looking beyond the biological model. Then we'll redefine health and illness entirely. After that, we'll explore the health belief model, examine ethics and patient autonomy, and finally, wrap up with community and mental health. Basically, we're zooming out layer by layer, from the individual all the way to society. Starting off with Section 1, Beyond the Biological Model. This is where we take a sociological view. So, for the longest time, medicine looked at health through a very specific, microscopic lens. The biomedical model basically ruled supreme. It viewed disease strictly as a biological malfunction, caused by an identifiable pathogen or some internal physiological disorder. And look, this model is absolutely crucial. It's given us incredible scientific advancements, but it's just insufficient on its own to explain health disparities. That is exactly where the sociological perspective comes in. This perspective shows us that social conditions, poverty, cultural beliefs, education, and our environment actively shape our health outcomes. You could literally have the best clinical diagnosis in the world, but if a patient can't afford their medication or lacks access to clean water, their outcome is going to be drastically different. Which brings us to Section 2, Defining Health and Illness. Because to really grasp this broader view, we have to rethink some basics. And this brilliantly illustrates the shift. Back in 1948, the World Health Organization dropped this absolutely groundbreaking definition that completely changed the paradigm of global healthcare. They defined health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. It recognized that health is total well-being. A healthy person isn't just someone walking around without a clinical diagnosis. They're someone who can function effectively across all areas of their life. Now, we toss the words disease and illness around like they mean the exact same thing, but they really don't. Disease is a measurable physical issue. Think of high blood pressure. A doctor can objectively measure that. Illness, on the other hand, is the subjective, personal experience of just not feeling well, and that is highly influenced by your culture and your personality. So someone can have a disease like hypertension, which is often called a silent disease, without experiencing any illness at all. Conversely, someone can feel deeply ill without a doctor finding any clinically detectable disease. And then we add a third layer to the mix, sickness. Sickness is the social recognition of illness. The sociologist Talcott Parsons developed this fascinating concept called the sick role. Essentially, society has to negotiate and agree that you are, in fact, sick enough to get out of doing the dishes or going to work. Two people with the exact same symptoms might be treated entirely differently based on their social status, their gender, or their cultural background. Let's keep moving. Section 3, the health belief model. If people know a behavior is unhealthy, why don't they just change it? Now, what's really interesting here is the psychology behind those patient choices. Imagine a patient trying to decide whether to start exercising to prevent heart disease. First, they ask themselves, am I personally at risk? That's perceived susceptibility. Then they wonder, is this disease actually dangerous? That's perceived severity. Next, they weigh the perceived benefits of the exercise against the perceived barriers, things like lack of time, cost, or just physical discomfort. Usually, they need a cue to action, maybe a stark warning from a doctor or seeing a family member get sick, to finally trigger a decision. And lastly, self-efficacy. Do they actually believe they have the ability to stick to an exercise routine? If even one of these links is broken, the behavior just won't change. Because let's be honest, behavior change isn't an overnight event, it's a journey. Patients move through very distinct stages. In pre-contemplation, they don't even recognize there's a problem. They might be in total denial. Then they move to contemplation, where they at least start thinking about making a change. Preparation is when they actually make a plan, like finally buying those running shoes. Action is doing the hard work. And maintenance is keeping that habit going over time to prevent a relapse. True healthcare isn't just handing over a prescription. It's about empathetic teamwork, meeting the patient exactly where they are on this ladder. All right, zooming out again for Section 4, Ethics and Patient Autonomy. We're moving from internal psychology to interpersonal dynamics. So, These are the core ethical principles guiding modern healthcare. And while all of these are vital, you've got beneficence, which is the duty to do good, and non-maleficence, the duty to do no harm. The one that has truly revolutionized medicine is autonomy. Autonomy is the absolute right of individuals to make informed, voluntary decisions about their own bodies. Historically, doctors played a very paternal role. They made all the decisions, and the patient was just expected to passively accept them. But autonomy shifted that power. It recognizes the patient as the ultimate boss. Even if a provider strongly disagrees with a choice clinically, if that patient is competent and fully informed, their autonomy must be respected. So the crucial point here is this massive shift in how providers and patients interact. For decades, the ultimate goal was compliance. The provider gives an order, the passive patient obeys. And if they didn't, well, they were labeled difficult. But modern medicine strives for concordance. Concordance is a true collaborative partnership. It's a shared understanding where the patient's beliefs, their cultural background, and their values are actively respected and integrated right into the care plan. It's teamwork versus dictatorship, and it leads to significantly better long-term outcomes and, honestly, much deeper trust. Finally, we hit Section 5, Community and Mental Health, resuming all the way out to society at large. We have to talk about this powerful and deeply sobering concept from sociologist Irving Goffman. He observed that mental health stigma creates a spoiled identity, where society defines individuals negatively simply because of a particular condition. We really have to frame stigma not as some personal failure, but as a severe systemic issue. Public stigma, self-stigma, institutional stigma, these things actively create social rejection. They prevent individuals from seeking the help they desperately need, isolating them at the exact moment they need their community the most. And think about the cyclical trap of poverty and mental health. The connection is undeniable. We see it clearly in these two prominent sociological theories. The breeder hypothesis suggests that stressful environments, poverty, and deprivation actively produce mental illness. On the flip side, the drift hypothesis argues that mentally ill individuals drift downward into lower social classes because their condition reduces their economic productivity. Regardless of which direction you think the current flows, both of these hypotheses clearly illustrate the profound link between social inequality and mental health struggles. You just cannot separate a patient's mind from their environment. Let's move to our next point and see how this all builds together. Because of this deep connection, our modern approach to care has completely changed. We've shifted away from isolating patients in institutions. Now the focus is heavily on community mental health. The goal is to keep patients connected to their communities through accessible care, active family participation, and social integration. It relies heavily on psychosocial rehabilitation, which is helping individuals build daily living skills and confidence, and a recovery-oriented support system that empowers them to live meaningful lives despite their challenges. The community itself literally becomes a vital part of the medicine.
Which leaves us with this final question. We've seen today how everything from our cultural beliefs to our socioeconomic status shapes our well-being. So, if health is socially shaped, what role will you play in your community's healing? Every interaction, every choice to fight stigma, and every effort to truly understand the person behind the symptoms contributes to the broader health of our society. It is a biopsychosocial world, and we are all connected within it. Thank you so much for joining me for this explainer. I really hope it shifted your perspective a bit. Keep learning, and I will see you next time.